So, good morning, everyone. Sorry for the slight technical delay. I am your ophthalmology educator, Dr. Vineet Sehgal, and you can see exclusively my video lectures on the Let's Crack NEET PG YouTube channel and also on the Unacademy Learning app. You can basically download it from the iOS store or the Play Store and use my code OPHTHAL10 to unlock the free platform. There are a lot of batch courses which are going on. The top educators throughout the country teaching you day in and day night. You can basically decide on what you want and basically then go and get the subscription and get the best of the knowledge from the best of the educators. If you want to go for the plus subscription, you can use my code OPHTHAL10. If you want to go for an iconic subscription, where you have an advantage of the Unacademy as well as the PrepLadder app, you can just there click the select iconic and then go for that subscription also. And remember, by using the code you can get a 10% discount on whatever course that you want, which would help you basically to crack the NEET PG as well as for your INI CET exam. So coming straight to my point, that is the topic that we are going to discuss today is the optical coherence tomography and the various macular disorders. Remember, OCT is an very important investigation nowadays, and the basic advantage of OCT is now that without being invasive, okay, we can basically detect the macular lesions or lesions anywhere in the retina or the optic nerve, and you can also see the layers of the retina. So it is something, an investigation which has revolutionized the treatment of the macular disorders or the retinal disorders. Also from these OCT we can basically know that where is the pathology. So out of the 10 layers of the retina and in the choroid, where are the deposits, where are the hemorrhages, how much is the retinal thickness, and how much it has improved. So not only it has a very important role in the diagnosis, it is also having a very important role in the treatment strategy of the macular disorders as well. Okay, so now I come to few definitions that you have to remember. First of all, what is macula? So macula is the area which is, can you see this area having a halo? So this area is around 5.5 millimeter in diameter, and remember the macula is the area which gives you the form of vision, the color, the contrast sensitivity, and the shape that you see in a patient, that is mostly because of the macula. So if you have a macular disorder, the patient would have some issues in the, that he would say, sir, I would not be able to see the shapes clearly, मुझे कलर ठीक से नहीं दिखाई देते हैं. ठीक है. So second thing that you have to remember is that what is fovea. So fovea is around the 1.5 millimeter of the macula. तो मैक्यूला के अंदर भी जो छोटा सा वन सेंट्रल 1.5 मिलीमीटर पार्ट है उसको हम फोविया कहते हैं, एंड दिस इज द मोस्ट सेंसिटिव पार्ट. सो मैक्यूला इज सेंसिटिव, फोविया इज मोर सेंसिटिव. Then we have the third one, that is fovea. So fovea is the central 0.35 millimeter of the macula, and very important is it has the lowest threshold of light. तो बहुत ही कम लाइट से भी ये एक्साइट हो जाता है. So what are, why it gets excited? Because of the presence of the cones there. Okay, so fovea is a region जहाँ पर सिर्फ हमारे cones होते हैं और कोई किसी तरह के cells नहीं होते. Okay, so फोविया के चारों तरफ एक छोटा सा एरिया होता है जिसको हम बोलते हैं फोवियल एवेस्कुलर जोन. सो फोवियल एवेस्कुलर जोन is around 0.8 millimeter in diameter and it does not have any blood vessels. It is a very important landmark when you do a fluorescein angiography. We would have a session soon on the fluorescein angiography also, but remember the most important points: macula, fovea, fovea and foveal avascular zone. And if any of the disorder is there, if any of the drusen is there, if any of the pathology is there, it can affect the eyeball and it can affect the vision very much. Okay, so I told you what are the functions of macula. It makes the best of the vision, color and the contrast sensitivity. And the techniques to identify macular pathology, the most important one is optical coherence tomography. So if you can see, this is a picture of optical coherence tomography. यहाँ पर अगर आप देख सकते हैं, so these are the 9 layers of retina. these are the 9 layers of retina. Okay, these 9 layers I collectively call them neurosensory retina. Okay, and this 10th layer, this is called retinal pigment epithelium. Okay, remember the neurosensory retina is in touch with the vitreous, and the RPE, that is the retinal pigment epithelium, it is in touch with the choroid. Okay, so whenever you are doing a optical coherence tomography scan, you can have two varieties there. Okay, so two varieties. One is that you can take a RNFL scan, retinal nerve fiber layer scan, which is very important for glaucoma, and other is you can take a macular scan. So in today's session, we would talk about the various macular scans of various macular disorders. Okay, chalo. So first of all is identify the spotter. So first type of image you can get like this. So your options are central serous retinopathy, macular hole, cystoid macular edema, or wet ARMD. So this is a patient who is suffering from, if you can see, these are the 9 layers. These 9 layers, I call it neurosensory retina. And this is the 10th layer, the RP. So there is a fluid collection, the blackish area that you are seeing. This is between the neurosensory retina and the RP. Okay? So basically there is something which is going on at the level of RPE and beneath it, which is causing the fluid accumulation, serous accumulation at the level of fovea. Okay, this is called central serous retinopathy, and another name of this disorder is foveal detachment. Okay, so this is a central serous retinopathy or a foveal detachment. Okay, remember this central serous retinopathy, the patient would come that, sir, I was having okay vision, but now what I am having is that I get some central scotomas, मुझे बीच में दिखाई नहीं दे रहा है, and the patient would say that, sir, earlier I was having emetropia. Emetropia means I was not having any refractive error, but now when I have done the AR, the automated refraction, I have seen a basically refractive error of +3. So what this is meaning is that there is a hyperopic shift of the patient. So very important point, whenever you are getting a central serous retinopathy is you would get a hyperopic shift of the patient also. This space where the fluid is basically accumulating, this space is called subretinal space. Okay, so these are few important points and how to distinguish between the central serous retinopathy and the other disorders, that you would have basically accumulation of serous fluid at the level of subretinal space. Okay, so this is the next question, identify the spotter. So here if you can appreciate that there are missing layers at the level of fovea, and these missing layers which are at the level of fovea, this is basically called macular hole. Okay, so the layers, even the layers of cones, they are also basically absent at this area. So the signs and the symptoms may be the same as per the central serous retinopathy, but they are more severe because there is a total loss of the layers there. It can be traumatic, it can be post-cystoid macular edema, or it can be idiopathic, this macular hole. But very important is that these macular holes, these are very difficult to treat, and you need to have a surgical intervention in the macular hole. And how would you do a surgical intervention? What you do is you basically remove the internal limiting membrane. You peel the internal limiting membrane of the patient and then it regrows. So the treatment of macular hole is ILM peeling. Okay, so just I am revising for those who have joined late. This is a patient who is suffering from central serous retinopathy, where you are seeing the subretinal fluid here, and this is basically the patient who is suffering from macular hole, where there are the layers of the retina absent at the region of center of the macula. So this is the macular hole. Okay, chalo, let's move to our next question. So identify the spotter. So this is another OCT image, but in this OCT image you can see that we are having cystic spaces in the retina. Okay, so we are having these cystic spaces in the retina, and these cystic spaces in the retina, they are basically called cystoid macular edema. This cystoid macular edema is very common in variety of the ophthalmic disorders. Okay, very important is you understand that cystoid macular edema, these cystic spaces, these are at the level of inner retinal layers. ठीक है, सो आपको दिख रहा है कि जो cystic spaces हैं वो रेटिना के बीच में है. Do not confuse it with the central serous retinopathy, where the foveal detachment or the accumulation is beneath the neurosensory retina. Here, the spaces are in the middle or in the inner retinal layers. यहाँ पर क्या चीज़ आपको याद रखनी है कि very important is that sometimes this can happen after a cataract surgery. So uncomplicated cataract surgery, you may have a cystoid macular edema there, and that is basically a term which I use for a syndrome. This is called Irwin-Gass syndrome. We would discuss more about the Irwin-Gass syndrome when we would discuss about the cataract surgery. But remember, a macular edema can be there after a uncomplicated cataract surgery also. Then it can be after uveitis. Then it can be due to some drugs also. So sometimes the questions are asked that what are the drugs that can cause a macular edema. So for this you can remember a mnemonic, that is NEET PG. So N goes with the niacin or the nicotinic acid. EE goes with the epinephrine. T goes with the tamoxifen. And PG goes with the PG analogs. Okay, so these are few important drugs which can cause a cystoid macular edema. One more thing that you have to remember, that sometimes this macular edema can be a cause of some more ophthalmic disorders also. Okay, so let's say the patient is suffering from uveitis, posterior uveitis or intermediate uveitis. Sometimes patients who are having a diabetic retinopathy, or even the patients who are having a retinitis pigmentosa. So these are some ophthalmic disorders. They can also cause a cystoid macular edema. Okay. So from here we get a point that it is not a cystoid macular edema is not a pathognomic of any particular disorder. It can be there in the variety of disorders. How to treat it? You would basically give the anti-inflammatory drugs to the patient. So what is the treatment strategy of cystoid macular edema? You would basically start the treatment. You would just basically give the topical NSAIDs to the patient. If the patient is not responding, you can give the topical steroids to the patient. If still the patient is not responding and it is because of the leakage of the vessels, then you can go with the anti-VEGFs like ranibizumab, bevacizumab. Also you can go with the intravitreal steroids like ozorodex. If the patient is not basically responding even then you can go ahead with the macular grid photocoagulation. Okay, macular grid photocoagulation. So these are the various treatment protocols which would be very helpful in a patient who is suffering from cystoid macular edema. Okay, so with this I come to my next question. So this is a patient who has got a fundus photo like this and a OCT picture like this. What is this patient suffering from? So here in this patient you can basically see in the fundus photo this area. So you are seeing discrete margins, yellowish spots on the macula. So these yellowish spots on the macula are called drusen's. Similarly, in the OCT, you can see that in the center of the OCT, there is a elevation of retinal pigment epithelium. This elevation of retinal pigment epithelium at the center of macula, this is because of some deposits in the Bruch membrane of the choroid. Okay, these are called drusen's, and remember, DR goes with DR. Okay, so drusen's are there in the dry ARMD. Okay, so here you can see there is no cystoid spaces, there is no accumulation of any fluid. These are basically, the pathology is coming from the choroid and basically elevating the RP. So this is called a dry ARMD. So there are two terms. One is a dry ARMD. One is a wet ARMD. ARMD means age-related macular disorders. So this disorder basically occurs after a specific age, let's say after 50 or after 60 years of age, and you would get some drusen's, hyperpigmentation, hemorrhages exclusively in the region of macula or paramacular area. The problem is that whenever these things occur, they can cause a decrease in the vision. This decrease in the vision is more seen in the wet ARMD as compared to dry ARMD. Remember, dry ARMD is more common in epidemiology as compared to wet ARMD, but wet ARMD is having a more disastrous complications on the vision as compared to dry ARMD. Okay, so this is, you can see a RP elevation. Similarly, you can have a picture of wet ARMD. Here, if you can appreciate this area. So this area, you are seeing a geographical atrophy, as well as you can see a scar and some hemorrhages here. Okay, so similarly, you can see there is a RPE. There is a massive RPE elevation on the optical coherence tomography scan. Okay, so this is basically called a patient suffering from wet ARMD. Okay, whenever you have a wet ARMD, you have two choices for the treatment. First thing is, you can do a treatment modality that is called photodynamic therapy. Photodynamic therapy basically uses the diode laser to photocoagulate the vessels, the new vessels which are basically starting from the choroid. Okay, and here we use a dye which is called vertipofrin. The vertipofrin dye is basically used in these patients, and what they do is they basically get accumulated in the new vessels, and then we can do a diode laser. If it is not responding, then the second choice we are having is we can use anti-VEGFs also. You would ask me, sir, why are you using anti-VEGF? Because anti-VEGFs are helping this patient wherever there is a massive neovascularization and macular edema. So it would act on both ways. It would decrease the formation of vessels and it would decrease the edema as well. Okay, that's why we can use anti-VEGFs here. So what is the pathogenesis? First of all is that the new vessels grow behind the macula. They break down the Bruch membrane. These vessels, because these are the new vessels, they do not have a very good wall. So they basically leak blood and fluid in the macular region, which would basically cause the scarring of the macula. Okay, chalo. So this is the picture where you are getting a wet ARMD. Another name of wet ARMD is choroidal neovascular membrane. Okay, this area, if you can appreciate, there is a scarring and the hemorrhage in the paramacular area. Okay, this is a wet ARMD. Now there are three types of wet ARMD. Topographically, I divide it into extrafoveal, juxtafoveal or subfoveal type of wet ARMD. What they do mean? So subfoveal is the most dangerous. So what I mean here is they are just beneath the foveal avascular zone. Okay, so if this is my OCT picture, these new vessels are basically around the center of the fovea. Okay, So they can basically be very dangerous to the patient and their treatment would be also difficult. Okay. So the next one is juxtafoveal, which is just around the foveal avascular zone, and extrafoveal, which is a bit distance from the your center of the macula. So from this I can understand that if they ask which is the most dangerous type of ARMD, then our answer is subfoveal. So subfoveal is most dangerous type of wet ARMD because it is at the center of the macula, and in these patients I use a photodynamic therapy. Okay, chalo. Let's move to our next question. Okay, so the next question is the test used for home monitoring of ARMD patients. Your options are modified Emsler-Dubois retinal chart, Hess chart, Maddox rod test, or Emsler grid test. Now here sometimes the students get confused between the Emsler grid and Emsler-Dubois retinal chart. So remember, whenever we are talking about the Emsler grid test, it basically is used for the home monitoring of the patient who is suffering from any macular disorder. If you can see in this picture, you are seeing a large square where there are a lot of small squares. So what I tell the patient is to see at the center of the square. But if he is not able to basically see the center of the square clearly, or there is a deterioration in the shape of the squares that he was seeing few weeks back, so this means there is a deterioration of the patient and this patient may need any intervention now. So because these ARMD patients, they are usually old age patients, they cannot come to the OPD again and again. So we can basically tell them that you can do a home monitoring of any functional deterioration of that sort. And if you feel there is a functional deterioration, you can basically come to us and we can have a look on them. Okay. So this is a Emsler-Dubois retinal chart. Emsler-Dubois retinal chart, if you can appreciate here, this is a depiction of the various lesions of the retina in a chart. So if you can see this blue area is basically nothing but a patient who is having a retinal detachment. Okay. So यहाँ पर आपको जो है inferotemporal एक retinal detachment दिख रहा है. Then you can see some lattices here, the brownish bands, you can see these are the lattices. Then the reddish area, these are the hemorrhages. Similarly, you can have exudates. So any lesion in the retina can be basically depicted on a Emsler-Dubois retinal chart, and this would help the residents for the training also. And whenever you have to basically, let's say a patient is having multiple lesions and you are basically taking the patient to the OT, during the surgery you can basically have a look on the chart and then you can have an idea where would you have a tear, where would you have a hole, and how would be the configuration of the retinal detachment when the patient have presented. Okay, so all these lesions can be depicted on the Emsler-Dubois retinal chart. Okay, so I just repeat once again the various lesions. So this is a patient who having a central serous retinopathy. In central serous retinopathy, you are having a cystoid. You are having a serous detachment between the neurosensory retina and the RPE. Then you have a macular hole where the layers are missing at the center of macula. Then you have an elevation of RPE. Okay, this is called ARMD. If the ARMD is because of the yellowish lesions which are discrete in margin only at the level of macula, I call it dry. When there is a reddish patch there and the patient is having a leakage also there, then I call it wet ARMD. Okay, and this is a patient having a cystoid spaces in the inner retinal layers. This is a patient of cystoid macular edema. So this slide you can take a screenshot and basically keep it in your safe so that you can revise it in the end how the different type of retinal lesions look in a OCT picture. Okay, chalo. So the last question of the day is bullseye maculopathy is due to which of the following drug? Remember, bullseye maculopathy have been a very important question, and this is a very important consequence of the patient getting chronically treated with the hydroxychloroquine. So what happens is that the retinal layers get damaged and usually you get a sub RPE deposits. So this is a retinal pigment epithelium. You can get deposits here, okay, in the hydroxychloroquine, and you would get a hyperpigmentation, okay, and surrounding it a hypopigmentation. This is called a bull's eye maculopathy, okay. It is seen in the patients who are suffering from hydroxychloroquine. So very important test which you can use in the patient who is suffering from macular disorder to see if the vision is basically deteriorating. You can use a multifocal ERG. You can use a multifocal ERG there. Okay, we would discuss more about the multifocal ERG when we would talk about the investigations in ophthalmology. So with this, I basically end this session. Hope you would have enjoyed this session. Please click on the Let's Crack NEET PG channel. Subscribe the channel for getting the notifications. You can basically subscribe for the plus course or the iconic course with my code, that is Ophthal10, and get a 10% discount. Okay, so with this, I end my session. Subscribe for the channel. Join our Telegram group, use my code Ophthal10 and hit the bell icon for the notifications. Thank you and